Okay, so these are my dermat notes from UWorld, and let's get to it. Primary syphilis, painless genital ulcers, cankers, herpes simplex lesions, painful vesicles, and erosions. There, red papules, shiny flesh colored with central umbilication. These are molluscum contagiosum. It's associated with cellular immunodeficiency. Secondary syphilis, mucus patches, gray, white, slightly raised lesions on tongue. You do RPR screen for it. Human papillomavirus causes condylomata acuminata, and these are your anogenital warts, multiple skin-colored, non-tender verrucous papule. Chemical or physical agents, trichloroacetic acid, podophyllene. Immune therapy, for example, imiquimod, and surgery you can do. For example, cryosurgery, excision, or laser treatment to treat this. Okay. Squamous cell carcinoma in situ, or Bowen disease. So it's like that. To diagnose it, you do punch biopsy, and this is also the same thing. Squamous cell carcinoma and squamous cell carcinoma in perianal region. Well demarcated, red plaque, high risk of HPV infection. Squamous cell carcinoma of the skin. Risk factors are sun, ultraviolet, ionizing radiation exposure, chronic scars, wound, burn injuries, and immunosuppression. That's the important one. Clinical features are scaly plaques and nodules with or without ulceration, SCC and C2, well demarcated patches, and plex. So, how do you diagnose it? You do punch biopsy or shave or excisional biopsy. Dysplastic and plastic keratinocytes, these things. Treatment is invasive squamous cell carcinoma. You do excision with 4 to 6 millimeter margins and Mohs micrography surgery. Probably won't remember that, but okay. Squamous cell carcinoma in situ is excision with 4 to 6 margin. CNE, that's curettage and electrodesiccation. Cryotherapy and topical 5-FU, that's 5-fluorouracil, and imiquimod. So that's how you treat those. That invasive squamous cell carcinoma, this is ulceration, that's tumor. Okay. Chronic atopic dermatitis. A lot of questions on these. Excoriated papules, lichenification, skin thickening from scratching. Okay. This is eczema. Okay. So acute palmoplantar eczema. Clinical feature here is recurrent acute episodes, deep-seated pruritic vesicles and bullous at hand and feet. The complication is desquamation, chronic dermatitis, secondary infection. This is the important stuff. Mostly this is the stuff you need to worry about, diagnosis and treatment when it comes to these things. You don't need to really identify it most of the time. They just ask you how would you do it. So diagnose it. Clinical feature usually adequate for diagnosis. Biopsy, intraepidermal spongiosis, and lymphocytic infiltrate. Treatment is topical emollients. Those are like lotions. Super high potency topical corticosteroids. I notice with most of these skin conditions, the go-to drug is corticosteroids and antifungals. Nummular eczema, this is a new one. Pruritic coin-shaped eczema patch. 1 to 10 centimeter in diameter. Okay, so it's chronic, round, coin-shaped. That's where they get their name, I think. Scaly plaques in regions of dry skin, primarily on the lower extremities. Numen is Latin for coin. Yeah. Lesion fits under a coin. Cause is uncertain, but frequent occurrence in the setting of chronically dry skin suggests decreased production of skin lipids. Treatment here is topical glucocorticoids, betamethasone, or dipropionate. Patient also counseled on measures that reduce dry skin like emollients, minimizing use of harsh soaps. Um, this is okay, and I guess you can figure it out once you know what it is. If you're going in blind, it's kind of harder to figure it out. And Nummular eczema again, scaly fissured plaque, and that. So now you know what that is. And it kind of looks like psoriasis. That's why I put it there. But this one is much smaller, and this one the margins are, widespread. So psoriasis vulgaris, erythematous plaque with a silvery scale. Treatment here is topical vitamin D analogs like calcipotriene. Okay, guttate, psoriasis. So these are 2 to 15 mm discrete erythematous plaques with fine scales. Kind of looks like a leopard print. Right, so again, same thing. Small, less than 1 centimeter, red papules or plaques with minimal scales. Sorry. Okay. Right. So these are widely scattered erythematous scaly papules and plaques. Typically follows a streptococcal infection like pharyngitis. More common in children. So differential diagnosed with small plaque psoriasis. So those are these things. We'll come to that. It occurs in patients with rheumatoid arthritis and those on TNF alpha inhibitors. Treatment here is UV phototherapy, topical glucocorticoids, and vitamin D analogs. Okay, so vitamin D for psoriasis, UV phototherapy, and topical glucocorticoids and vitamin D analogs. Okay. Plaque psoriasis treatment is glucocorticoids again. Other stuff is used often for face where glucocorticoid induced skin thinning would be a problem. Okay. Again, plaque psoriasis. Here, don't confuse it with molluscum contagiosum. Erythematous plaque with thick scaly scales. That's psoriasis. Again, same thing. So plaque psoriasis. Skin lesions, well-defined erythematous plaque with scaly silvery scale, extensor surface, knees, elbows, hands, scales, scalp, back, nail plates. Most common vignette is about a guy who is like a carpenter or handyman who's working on his knees and comes in contact with chemicals and stuff, and then he comes in itching his knees or under his elbows. It's usually psoriasis. Extradermal manifestations: nail pitting, conjunctivitis, uveitis, psoriatic arthritis. Treatment here is topical is high potency glucocorticoids, vitamin D analogs, tar, retinoids, calcineurin inhibitors, and tazarotene. Treatment here is again ultraviolet light and phototherapy. And treatment for systemic is methotrexate, calcineurin inhibitors, retinoids, apremilast, and biologic agents. Okay, methotrexate was a new one. We were accustomed to glucocorticoids and vitamin D. and none of these other ones, so we'll try to remember those. Psoriasis now. So these are chronic, well-demarcated scaly plaques, vesicles, and severe pruritus are not common. Vesicles and severe pruritus is not common. Okay, so that thickened plaque with white silvery scales. Okay, so here is psoriasis from the first aid from step 1. It says papules and plaques with silvery scaling, especially on knees and elbows, acanthosis with parakeratotic scaling, nuclei still in stratum corneum, Monroe microabscesses, increased stratum spinosum, decreased stratum granulosum. Auspitz sign, pinpoint bleeding spots from exposure of dermal papillae when scales are scraped off, associated with nail pitting and psoriatic arthritis. And these are the subtypes of psoriasis. So one is large plaque psoriasis, insidious onset, thick scales, typically on back, extensor elbows, and knees. Then you have the small plaque psoriasis. These are insidious onset plaques less than 1 centimeter, distinguished from guttate psoriasis based on history. Okay, so you got the large one, you got the small one, which is less than 1 centimeter, and then you got the guttate drop-like psoriasis, the leopard print one. Acute onset plaques are also less than 1 centimeter, associated with streptococcal pharyngitis. So the leopard one is the one with the, I don't know, leopards don't roar, but they meow, I guess. I don't know. And since they meow from the throat, they get pharyngitis. Try to connect it that way. For example, in children. Okay. Pustular psoriasis. Acute onset painful plaques with pustules with or without systemic symptoms, for example, fever, typically on palms and soles. Pustular psoriasis, again, acute onset painful plaques with pustules with or without systemic symptoms like fever, typically on palms and soles. And then you have erythrodermic psoriasis here. Severe widespread erythema, for example, 75% of body surface, can be triggered by medications, for example, glucocorticoids, or infection, for example, HIV. Okay. Inverse psoriasis. Okay. So it's unlike common plaque psoriasis, which predominantly affects extensor surface. Inverse psoriasis affects the intertragenous regions. So basically, on the other ones, it was like outside of the elbow or the knee. Here, it's over the inside. However, this psoriasis variant presents as smooth plaques, like that, with minimal to no scaling. Okay. Tinea fascia. This is erythematous scaly annular plaque again. It's singular, solitary, right? So oral antifungal is good enough. Terbinafine and itraconazole. Don't confuse it with the silvery scaly one, which was the stuff. Xerosis, that just means dry skin. It says right there. Again, xerosis, dry skin. Treatment is emollients. Okay. Plantar warts. These are multiple hyperkeratotic verrucous papules. These are due to HPV. Treatment here is it usually resolves by itself, but if it's persistent, you can use liquid nitrogen and salicylic acid. Flat wart, verruca plana. Flat skin colored varicose papule, again it's HPV. Common warts or Verica vulgaris. Brown cauliflower like papules, also HPV caused by that. This is also hyperkeratotic skin colored papules, Verica vulgaris again. Sorry, excuse me. So usually you can cross out and eliminate and exclude a lot of options from the ones they give you to get to these. Seborrheic keratitis, papules with a rough surface and stuck-on appearance. This was very popular in step 1 U World, I remember. Happens to over 50 years of age patients. Okay, in the sun exposed part of the body. Lichen planus, pruritic pink papule, polygonal papules on wrist. Right, on the 5 P's that was there. Again, same thing, polygonal. Oral lichen planus, you'll see lacy white streaks. Try to get used to seeing these instead of this for lichen planus. It's called the Wickham stria, the white lines in your buccal mucosa. Same thing right here. These lichen planus, pruritic purple pink polygonal papule plaques. Okay. So lichen planus, it is an autoimmune disorder driven by CD8 T cells and may occur after exposure to a trigger such as infection, medication, or contact allergens. It's associated with hepatitis C, associated with ACE inhibitors, thiazide, diuretics, beta blocker, and hydroxychloroquine. Wickham stria, we saw what that is, and then there is Koebner phenomenon, the appearance of new skin lesions on previously unaffected skin secondary to trauma. Okay, so the appearance of new skin lesions on previously unaffected skin secondary to trauma. So you get hurt because of something and then you have new skin forming over there. I don't know what that means. That's sus. Let's see. The appearance of new skin. Says the same thing. Oh, okay, so like that. So minor scratches and now they have skin growing over there. Okay, so it's not unique to just lichen planus. Got it. So lichen planus, 5 P's, clinical findings. These are not that important. This you can figure it out. It's the stuff that they usually test you on. But 5 P's, pruritic purple pink polygonal papules and plaques, lacy white network of lines, Wickham stria. Location is skin. For example, ankles and wrists, oral mucosa, white plaques, papules and plaques, with or without erythema, mucosal atrophy, ulcers, and genitalia. Disease associations, hepatitis C, medications, ACE inhibitors, thiazide, diuretics. Natural history is chronic symptoms. You'll get formation of lesions at site of trauma. Again, the Koebner phenomenon. Spontaneous resolution within about 2 years. Treatment is topical high-potency glucocorticoids, for example, betamethasone, and widespread lesions, systemic glucocorticoids, systemic glucocorticoids and phototherapy. Okay, so that and that. So mostly just steroid is what you give. And it's associated with hep C and ACE inhibitor and thiazide diuretics. Aphthous stomatitis, canker sores. Aphthous. Remember, canker sores are also known as Aphthous stomatitis or Aphthous ulcer. Okay, manifestation of Crohn's disease, painful, discrete, with white base. This is oral candidiasis, thrush, AIDS-defining illness. Viral xanthem, it's erythematous mucopapillar eruption. Okay, I don't remember a question on this. I think it's just one of those explanations that I've got this picture from. Psoriasis rosacea, colorette or scale, herald patch, single oval sharply demarcated patch. Okay, good thing. So Psoriasis rosacea is characterized by numerous small oval scaly plaques, often with an initial lesion, or also known as herald patch, that is much larger than the latter lesions. So all of these are smaller than this big one right there. It is typically seen in children and young adults and usually occurs on the trunk and proximal, not distal, extremities. In addition, the rash typically resolves within 6 months of presentation. Okay. So it is typically seen in children and young adults and usually occurs on the trunk and proximal extremities. In addition, the rash typically resolves within 6 weeks of presentation. Okay, again, that's the same thing. Kind of looks like SLE, but it's not. So remember, that is also part of Psoriasis rosacea. Okay. None of these are kids and young adults, as they say over here. But anyways. Papulopustular rosacea. Erythematous papule, erythematous pustule. So you get a pustule and a papule. One that has pus, one that doesn't. Treatment here is metronidazole. Allergic contact dermatitis, poison ivy. This is the one where if you get linear lines, it's usually contact dermatitis, right? So linear formation, leaf stroke of red papule vesicles. Treatment is topical glucocorticoids. Allergic contact dermatitis, pathophysio is type 4 hypersensitivity reaction. Common triggers are poison ivy, nickel. Nickel is important. Got a couple of questions on that. Dyes, topical medications, skin care products. Okay. Clinical presentation is acute pruritic, red indurated plaques with vesicles and bullous, chronic lichenification and fissuring. Diagnosis here is clinical findings, patch testing for persistent cases. Treatment here is avoidance of suspected allergens and topical or systemic local corticosteroids. All right. Here, nickel allergy right here. It's from a belt buckle. Watches and jewelry is a common trigger for chronic allergic contact dermatitis. Chronic ACD presents chronic itching and lichenification. It gets a little dark. Avoid allergen and give corticosteroids. 21-year-old hiking trip plus itchy erythematous rash that progressed into small blisters like that. Reported falling into a bush and getting insect bites. This was activation of memory T cell type 4 hypersensitivity reaction. Poison ivy is also known as rust plants. Here, this is also poison ivy dermatitis. The tabula erythematous papule. You see a little line, linear streaks over there. Erythematous papule and vesicles and linear or streaking arrangement. This is a presentation, can be diffuse as well. History was about a patient gardening and then getting small papules and then blisters that started oozing yellow fluid. Here, history was for a janitor with itchy dry skin or dirt on dorsum hand, and you see fissures. It was irritant contact dermatitis. Okay. Atopic dermatitis, papular variant, and that. Okay, papules. Okay, so the history here was 48-year-old dude with a rash forehead on to the nose to chin, with dandruff in his hair, greasy looking, fine yellowish scales on erythematous base. This is called seborrheic dermatitis. Scaly erythematous rash and skin folds around the nose, eyebrows, ears, and scalp. Seborrheic dermatitis is, again, same thing. Erythematous plaques with greasy yellow scales on central face. Same thing. On skin, eyebrows, and nasolabial folds. It's just dandruff. Scaling with surrounding erythema. Again, this is seborrheic dermatitis. Okay. Okay, so this is acute urticaria. Etiologies are medications, insect stings, infection, rheumatologic disease, and many cases are idiopathic. Now, pathophysiology is mast cells release histamine, and you get dermal edema. Clinical features here are pruritic erythematous plaque, for example, veals. Clinical feature, again, each veal lasts less than 24 hours. Urticaria duration is less than 6 weeks, diffuse or localized. Evaluation is no workup for first episode. Allergy testing if specific trigger like food is suspected, and lab testing or biopsy if systemic symptoms are present. Treatment and prognosis. You give second generation antihistaminics, add H2 antihistaminics for systemic corticosteroids if it's severe. 2/3 of cases self-resolve. Antihistamines are preferred. Corticosteroid is reserved for more severe symptoms. Okay. Right. Okay. Senile purpura is that and that. So ecchymosis on sun damaged or older skin, residual brownish discoloration due to hemosiderin deposition. This is often in areas exposed to repeated minor trauma like dorsum of hand. So 80+ year old, usually vignette is about scattered purple area on areas on her hands and forearm without pain or itching. Thin, hyperpigmented skin with several flat, dark, ecchymotic uh, areas over the dorsum of both forearms. It happens due to perivascular connective tissue and atrophy. Oh, perivascular connective tissue atrophy. Sorry. Tinea purpura usually presents with ecchymosis in elderly patients in areas exposed to repeated minor trauma. For example, extensor surface of hands and forearm. It is due to age-related loss of elastic fibers in perivascular connective tissue. Tinea purpura is not dangerous and requires no further evaluation. Here we have tinea vesicular or Psoriasis vesicular. Okay. So pathogens is superficial skin infection by Malassezia species, commensal fungus converted to pathogenic filamentous form with exposure to hot and humid environments. For clinical features are hypopigmented, hyperpigmented, or erythematous macules, distribution, trunk and upper extremities in adults and adolescents, face in children with or without fine scale and pruritus. Diagnosis here is clinical. You do a KOH preparation and you'll see hyphae and yeast cells in a spaghetti and meatball pattern. Treatment here is topical ketoconazole, terbinafine, or selenium sulfide. Okay, fungal infection is by Malassezia M. globosa or M. furfur. Only tinea infection that's not caused by dermatophytes, and that is important. Okay, so only tinea infection that's not caused by dermatophytes, which require keratin for growth. So vignette here was hypo or hyperpigmented macules occurs due to sun exposure. Lesion may be mildly itchy on a beach or a swimming pool. Because of this, you may want to pick avoid sun exposure when you see dark macules, but it's false. False. Okay. So treatment here is ketoconazole, terbinafine, or selenium sulfide. Tinea corporis, red annular patch, central clearing, and scales. Again, same thing on the body, same thing on leg, and here you have it on the arm or the calf, can't tell, probably the arm. Okay. Diagnosis here is you do it with KOH, microscopy of skin scraping. Treatment is topical antifungals, clotrimazole, terbinafine. Okay, so these are the dermatophytes. Okay, here it was said that this is the only one that is not caused by dermatophytes. Okay, Malassezia furfur. And okay, risk. So clotrimazole and terbinafine. Risk factor for dermatophyte infection: environmental exposure is warm, humid environments, direct contact with infected person, fomites, or public showers. Contact with animals, for example, kittens. Patient factors: concurrent dermatophyte infections, autoinoculation, occlusive clothing, obesity, and peripheral artery disease. Immune deficiency is diabetes mellitus, HIV, or systemic glucocorticoid therapy. So all of these can cause this. Along with treatment of rash, do HIV screening test. Okay, so When you get this tinea corporis, do HIV testing along with treating it. Okay, so tinea corporis, ringworm. Risk factors are athletes who have skin-to-skin contact or humid environment or contact with infected animals, like for example rodents or kittens. Presentation is scaly erythematous pruritic patch with centrifugal spread, subsequent central clearing with raised annular border. Treatment here is first line localized topical antifungals, or for example clotrimazole or terbinafine. Treatment here is second line extensive oral antifungals like terbinafine or griseofulvin. Here the history was that they adopted cats, so it kind of looked like ringworm infection, so terbinafine cream is the answer. Here it's a Lyme's disease. Treatment here is doxycycline. Alopecia areata, patchy hair loss with normal underlying scalp. Treatment is corticosteroids. Pharmacological treatment of alopecia areata depends on the size of the lesion. For limited lesion, for example, less than 50% of the scalp, intra-lesion corticosteroids like triamcinolone is preferred for adults. Topical corticosteroids can be used as an alternate and are preferred in children. For extensive, for example, more than 50% of the scalp, or refractory lesions, oral JAK inhibitor, for example, baricitinib, or topical immunotherapy, for example, diphencyclopramide, which stimulates hair growth, can be used. These are not really tested on. Here you're just going to have to figure out what it is from the picture. That's what the test is usually, but if I've written this, that means that was tested on. This is just there to, I think it was just FOMO. I didn't want to miss anything out, so I placed that there. Okay, trichotillomania, patchy hair loss, alopecia with hair regrowth of variable length. Right. Treatment here is cognitive behavioral therapy. Okay. So, drink water, guys. Okay. So usually this is the thing. These are some of the hair loss things that they'll test you on. So one is alopecia areata. You get patchy hair loss with normal underlying scalp. Here, you won't get hair, baby hair looking either. It's just going to be smooth. Whereas here you get a little bit of hair, like it's not going to be smooth. They're going to be patches, but you're not going to see them completely gone. So that's how you know it's trichotillomania, and it's seen in women more commonly. So here treatment is cognitive behavioral therapy. And then you had telogen effluvium. It's just hair loss due to stress. Causes thinning of shaft and hair shafts. So telogen effluvium, clinical finding is acute diffuse non-inflammatory hair loss, scalp and hair fibers appear normal, hair shafts easily pulled out, hair pull test. Triggers here are severe illness, fever, surgery, pregnancy, childbirth, emotional distress, endocrine or nutritional disorders. Management here is address underlying cause, reassure, and it's self-limited disorder. Another hair loss thing they can test you on is female pattern hair loss. So midline hair thinning in the crown. So this is, don't confuse this with either of these, right? Uh, it can be male or female pattern baldness. Treatment is minoxidil. Female and male pattern baldness or hair loss. Pathogenesis, follicular miniaturization, shortening of hair growth phase. Men, effect of dihydrotestosterone on genetically susceptible follicle, and for women, isolated idiopathic, most cases, or hyperandrogenic states like PCOS. Clinical features: chronic progressive hair thinning and shortening. Men, vertex, frontal hairline, temporal areas. Women are seen with vertex, hair loss in vertex, and frontal scalp, sparse hairline. Okay. Management is, in men it's finasteride and minoxidil, and in women it's only minoxidil. Okay. Female hair loss, female hair loss. So don't confuse this with, again, any of these. Okay. Here it's variable hair lengths, whereas here it's not going to be variable. Androgenetic alopecia, frontal temporal hair loss, and here you have hair loss at vertex and mid frontal scalp. Okay, this is herpetic Whitlow due to HSV, again vesicles on an erythematous base. Don't confuse these with which ones? The Coxsackie virus or rickettsia or mountain spotted fever thingy, and syphilis, because they have rashes on the palms and sole. This is not the same. This is not a rash. This is a vesicle. So herpetic Whitlow, it happens because of herpes, focal area of group vesicular rash on erythematous base. It just means it's red. The rash is, and the vesicles are on top of it. Treatment is antiviral, so acyclovir. Okay. Not secondary syphilis, it's diffuse symmetric macular papular rash. Okay, so, and it's not rickettsia. That thing manifests with headache, fever, and rash, and diffuse macular rash that turns petechial. Okay, Whitlow. Lesions are painful but not pruritic. Okay, so these are painful. Herpes zoster shingles happens in dermatomes, right? So look out for this presentation in someone that's immunocompromised. Okay, that's when these come out. So patient was taking infliximab in the vignette, TNF alpha inhibitor, plus itching and burning pain under it. Coxsackie virus now. Bilateral maculopapular or vesicular rash on hands and feet. Oral lesions are present too. Here, hand, foot, mouth disease. This is Acetosis vulgaris. Kind of looks like xerosis, but it's not, because this is flaky. It's rough, dry, scaly skin, especially during winters, happens throughout life. It's mild itching, but no erythema or exudate. Try to treat with emollients, but it doesn't make it go away. That's what the vignette said. So increase major and minor lines in the palms. Okay, so like that, like that. Um, okay, so Acetosis vulgaris. There's loss of function and filaggrin gene, so impaired epidermal barrier, reduced skin moisturization. Clinical features on so onset in infancy and early childhood, diffuse scaly skin with mild pruritus, and so mild pruritus, worse on extensor extremities, pairs intertriginous areas. Associated conditions are keratosis pilaris, palmar hyperlinearity, and atopic disease. Diagnosis: how do you diagnose this? Is clinical findings, biopsy if uncertain, reduced, absent granular layer in epidermis. Therapy is long baths to remove scales, moisturization, and keratolytics. For example, urea, alpha hydroxy acid, and salicylic acid. Treatment is do it. Um, okay, I don't know what that means now. Um, but okay, so acne mechanical, mechanical. Um, Patient with crutches has mechanical irritation of pilosebaceous follicles in axilla bilaterally. So that's what it's called. So it's acne due to mechanical causes like crutches pressing against pilosebaceous follicles, causing acne. Okay. So I think if I remember correctly, it was a dude who broke his leg for some reason, and then he got crutches to walk around with, and in a couple of days he came back to the doctor showing acne over there, and they were asking what's the cause. Most of these here, you have to identify them. If it seems like there's too much over here, most of the time they're just asking to identify it. It wasn't that complicated. um, Bullous pemphigoid. Okay, so remember this from step 1. Tense bulla, background urticarial rash, and erosion ruptured bullas. Bulla is below, so this is the one with the antibodies in the basement layers. Treatment: topical clobetasol. It is high potency topical corticosteroid, good for extensive disease. Drink water. Okay. It is high potency topical corticosteroid, clobetasol, good for extensive disease. Systemic therapy is oral doxycycline, oral corticosteroids, although it is not as effective as topical one. Mostly skin conditions go with topical stuff over systemic most of the time, not all the time. Okay, bullous pemphigoid. Clinical features: age is usually over 60, pruritic tense bulla, rare mucosal involvement, prodderm, or eczematous urticaria or like rash. Associated disorders: dementia, Parkinson disease, depression, bipolar disorder. Diagnoses are histology, subepidermal cleavage, immunofluorescence, linear immunoglobulin G and C3 deposition along the basement membrane. Serology is autoantibodies to Bullous pemphigoid antigens, hemidesmosomes. Treatment here is topical therapies like high-potency corticosteroids like we just went over, clobetasol, and systemic therapies are corticosteroids and doxycycline for bullous pemphigoid. Now, dermatitis herpetiformis. This is because of celiac disease. It's autoimmune eruption on skin, found on elbows, knees, and buttocks. Pruritic erythematous grouped papules and vesicles. That little band-aid thing is doing overtime there. Okay, so in the buttocks, elbows, and again, this is rosacea. We already went over this up there, but here it's in more details. Treatment is metronidazole. Here, yes, is rosacea. Actually, that was rosea, I believe, right? What was it? Just there. Tuberous is rosea, so I think just don't go here. Wrong place to place that picture. So I'll just do that again. Herald patch and the Christmas tree pattern. This does not go here. The SLE looking type. Okay, so rosacea. Treatment is metronidazole. Treatment of rosacea. General measures are avoidance of sun exposure, hot spicy foods, alcohol, gentle cleansers, and emollients. Erythematotelangiectatic rosacea, flushing erythema and telangiectasia. Topical brimonidine, laser intense pulse light therapy. For papulopustular rosacea, small papules and pustules, first line is again topical metronidazole, azelaic acid, and ivermectin. And second line is oral tetracyclines. Pemphigus rosacea, irregular thickening of skin, oral isotretinoin is what you give, and laser therapy or surgery. And for ocular rosacea, burning, foreign body sensation, blepharitis, keratitis, conjunctivitis, corneal ulcers, and you give lid scrubs and ocular lubricants, and topical and systemic antibiotics like metronidazole and macrolides. Here, it's hard to confuse it with SLE because of the presentation and the question stem itself, and like if they tell you it's like 60-year-old lady, it's usually gonna be this and not SLE. Same thing here. It's just repeating. Ocular conjunctival hyperemia, lid margin, telangiectasia. Treatment is avoidance of triggers, sun protection, gentle cleanser or emollients, topical metronidazole for papulopustular type, laser, and topical pyrimidine. Here usually just ask you to identify what it is. So erythrotelangiectatic history had photosensitivity, and they drank wine and flushing happened. Seasonal allergy with fluticasone nasal spray and loratadine was treated, and erythema and small telangiectasias were seen in the nose, cheeks, and chin. That's what the vignette had, and you were supposed to pick rosacea from that. SLE rash is darker in the color and spares. Right, so again, how do you differentiate with SLE? So SLE rash is darker in color and spares nasolabial folds. Okay, so nasolabial folds like there, right there. They spare those and is not affected by alcohol intake. Okay, so here flushing happens because of alcohol. And you will see other SLE symptoms like constitutional symptoms, arthralgias, and oral ulcers. So this is the papillopustular type that you give tetracyclines and uh, ivermectin, metronidazole, azelaic acids for. This is phymatous type. This one, irregular thickening of skin. You give oral isotretinoin and laser treatment and surgery. Okay. Hyperkeratotic actinic keratosis, erythematous base, and thick scales. Treatment here for hyperkeratotic was cryotherapy or topical 5-fluorouracil. These lesions are precursors to squamous cell carcinoma. Actinic keratosis, uh, I think the one we went over was seborrheic keratosis. This is actinic one. Nope, that's right here. Okay, so this is the popular one. I think I confused the two. I always do that. Deep wrinkles, foot damage, and scaly papules, plex, sandpaper-like. Okay, so this is the most popular one from step 1, I remember. Scaly papules, sandpaper-like texture. Okay, so then what is seborrheic keratosis? This is the mold stuck-on type thingy where you can just, if you can, I don't know, slide a knife under it, it will come off. Distinctive features of seborrheic keratosis include the following. It's round and ovoid shape with well-demarcated border, often described as a stuck-on appearance, velvety or greasy texture, or flat, with flat, fissured, or papillated verrucous surface, asymptomatic or mild pruritus, stable or slow-growing course. It's benign epidermal tumor, stuck-on appearance. Diagnosis just clinical based. Treatment is usually unnecessary. If there are numerous of these, then it can suggest lesser trillet sign, and then you get it checked out. Stuck-on appearance right there. Okay, that's just there to intimidate you. And superficial basal cell carcinoma, right there, red macule, atrophic appearing centers. Here, treatment is topical 5-fluorouracil. Impetigo, the sweet one, honey-colored crust, plaque. Treatment is mupirocin. It's a topical antibiotic. It can only work on MRSA. Eczema. This is erythematous plaque with ulceration. Eczema is a streptococcal skin infection related to impetigo. Okay. It can, excuse me. It can, water break. It can form round erythematous plaques, but presents actively and is often associated with pustules and small ulcers. Eczema is different from eczema gangrenosum, which is seen with Pseudomonas bacteremia and presents as painless red macules, quickly evolving into vesicles and necrotic ulcers. Yeah, so they're gonna test, if they test you on this, you're gonna have to figure out if it's this or is it Pseudomonas cause. So this is not because of Pseudomonas, it's because of streptococcal skin infection related to impetigo. Okay, it forms round erythematous plaques, but presents actively and is often associated with pustules and small ulcers. Okay. Treatment for acne vulgaris. If they already tried tazarotene and benzoyl peroxide, you give clindamycin. You don't give isotretinoin, especially because it's a young girl that's sexually active. Okay. Treatment for acne vulgaris. So there are three types. There's comedonal acne. So it's closed or open comedones on forehead, nose, and chin. May progress to inflammatory pustules or nodules. Treatment is topical retinoids, salicylic, azelaic, or glycolic acid. Inflammatory acne. Inflamed papules on less than 5 millimeters and pustules. Erythema, right? So treatment here would be, if it's mild, topical retinoids and benzoyl peroxide. If it's moderate, add topical antibiotics like clindamycin and erythromycin. And if it's severe acne, then add oral antibiotics. If it's nodular, like these are large, more than 5 millimeters, nodules that can appear cystic. Nodules may merge to form sinus tracts with possible scarring. So treatment here would be, if it's moderate, there's no mild here. So it starts from moderate, topical retinoid, benzoyl peroxide, topical antibiotics, the big ones. Severe, then add oral antibiotics. And unresponsive, if it's unresponsive to any treatment, and severe, then you go to oral isotretinoin. I believe you do pregnancy test before you prescribe this. Okay, so DLE most commonly affects sun-exposed regions of the head and neck, but may also involve the chest and upper extremities. Okay, the lesions tend to slowly expand over a period of months to years, especially leading to dermal atrophy and scarring. The rash often extends into hair follicle, resulting in scarring alopecia. DLE is a chronic skin condition of sores with inflammation and scarring favoring sun-exposed areas. These lesions develop as red, inflamed patch with scaling and crusty appearance. And I wrote DLE like I would remember what that is, and I do not. Let's see if internet remembers. Discord lupus erythematosus, of course. I should have known what that is. Okay, it's a chronic condition, sores and inflammation, scarring favoring the face, ear, scalp, and at times on other body areas. Okay, I think it's just late. I knew what that was. Necrobiosis lipoidica. Okay, so that's what that looks like. All of these are starting to look the same to me now. It is a rare, chronic, and idiopathic granulomatous disease of collagen degeneration. It is characterized by confluent annular lesions with a yellowish brown hue, dilated blood vessels, and epidermal atrophy. It typically affects pretibial skin and is most common in patients with diabetes mellitus. Okay, so I don't remember this being tested on, but since I've written 3 points on it, it probably was, and I didn't get it right. So I think it's a new concept. Necrobiosis lipidica. But when it's something like this, all the other ones won't make sense because you will know what the other options are, and this is the odd one out, so that's the one you will go with. Okay. Systemic sclerosis, scleroderma, thickening one. Causes induration and hardening of the skin, most commonly at the hands, fingers, and face. Ulcerations are typically at the fingertip. Okay. This one is, they'll tell you that there's hardening of the skin, and then they'll give you this, so you won't confuse it with, like, I guess with low or something. This is the cherry hemangioma. They don't regress spontaneously. It's common in aging adults, and it's benign and don't require any treatment. Uh, Basal cell carcinoma. Basal cell carcinoma appears as fleshy nodule with ulceration. Um, Basal cell carcinoma is associated with sun exposure, most common on the face, neck, and extremities. Remember how it looks, and don't confuse it with squamous cell carcinoma. Ulcerated center, pearly rolled raised border. You'll be asked to identify these. Ooh, that's a cool eyeball. Cavernous hemangiomas, also known as cavernous malformations, consists of dilated vascular spaces with thin-walled endothelial cells, softly compressible masses. Can occur on the skin, mucosa, deep tissue, and viscera. Associated with one Hippolindo disease, and moving on. This is Kaposi sarcoma, herpes 8, um, reddish purple, red, dark vascular plaque and nodule. It's seen in HIV. Okay. This is also Kaposi sarcoma. This is also Kaposi sarcoma. And they underwent a kidney transplant at 35. Multiple red, non-tender lesions were seen. Lesions typically arise within the first year of therapy and appear as multiple violaceous red or brown papules that do not itch or cause pain. Sorry about that. I'm gonna drink more water. Okay. Strawberry infantile hemangiomas appears during first week of life. They grow rapidly and then regress spontaneously by age 5 to 8. Okay, so strawberry hemangiomas, they sound similar to cherry ones, but cherry ones happen in older adults, aging adults, and they do not regress. Whereas this one, they regress by age 5 to 8. So if they ask you how would you treat it, you don't, you just let it be and reassure them that it's going to go away. Bright red near the epidermis and more violaceous when deeper. Interdigital scabies, you know this one. Pruritic excoriated papules and the finger webs. Scabies. Um, they'll tell you it's itchy, it's in the interwebs. Um, it's first at night, right? So it's over there. Treatment is 5% permethrin or oral ivermectin, and the other stuff like clean clothes and treat other members, etc. Okay, so the one you need to remember is permethrin. Here you have epidermolysis bullosa. Okay, it's characterized by bullous erosion, ulcers, friction-induced blisters on palms and soles. Golfing or hiking, triggered by minor trauma, no residual scarring but may have chronic thickening of the skin of the feet. Okay, infants with epidermolysis bullosa is simplex may develop oral blisters with bottle feeding. Subtypes are simplex, which is the most common one, junctional dystrophic Kindler syndrome. Again, they'll ask you to identify what this is, and none of the other options will make sense because you will know what those are, and then you'll pick this uh, after doing the differentials, and you'll get it right because it's a new concept and you knew all the other ones. Okay, so acrocordion is this. Soft, skin-colored, pedunculated papule skin tags. So these are just skin tags in axillary region. Okay, so skin tags are also called acrochordon. You need to know that. It's often seen in areas of friction. Okay. You already know how to identify this from step 1. Melanoma, asymmetrical pigmented lesion with irregular border and color variation. Variation. Like that. Like that. Okay. Solar lentigo. These are uniformly pigmented macules of sun-exposed skin. So these are the sunspots you see in elder people. It is the result of intraepidermal melanocyte hyperplasia. It is most common in older individuals and is characterized by round or oval macules with even pigmentation. Here you have erythema marginatum. I think this is the only picture they have for this. Let me see if there are more, because I remember seeing the same picture from step 1 UWorld. Okay. So Dermnet has that. Alright. So that's what that looks like. This is erythema migrans, target 1. And here we have erythema nodosum. This one's important. They test you on this. You should be able to identify that they're tender erythematous nodules and plaques on lower extremities. It is the delayed hypersensitivity reaction, inflammation of subcutaneous tissue. It's associated with infection. Streptococcal pharyngitis, autoimmune sarcoidosis, or inflammatory processes, inflammatory bowel disease. Polyarthralgia, fever, and malaise are common. Okay, so erythema nodosum, tender erythematous nodules and plaques on lower extremities. Here we have they had history of cystitis, which was treated with TMP-SMX and had similar rash before. It was acute onset, numerous painful spots, and dark lesions on her leg. So erythema nodosum. Same thing, indurated, tender, deep-seated nodules. Erythema multiforme. This is erythematous targetoid lesions, and there are multiple of them. And there's central vesicles bullous. Okay, so from first aid of step 1, erythema multiforme associated with infection, for example, Mycoplasma pneumoniae or HSV, drugs, sulfur drugs, beta-lactams, phenytoin, presents with multiple types of lesions, macules, papules, vesicles, targets, lesions. Looks like targets with multiple rings and dusky centers showing epithelial disruption. Erythema multiforme, pathogenesis, self-mediated immune response, commonly triggered by infection, HSV, Mycoplasma pneumoniae. Clinical presentation is in skin. You see acute onset of target lesions, like that right there, that like that. Pale edematous middle zone, dusky centers, often with bulla and ulceration. Mucosa, for example, genital, oral, painful bulla and erosion. Diagnosis is clinical features, skin biopsy if atypical presentation. Management is acute episodes, supportive care with or without topical corticosteroids. Recurrent episodes, consider suppressive antiviral therapy like acyclovir. Okay, so here you're supposed to figure out, because it kind of looks like impetigo, but it's not, or maybe even like seborrheic dermatitis. But this is target cells, so targetoid, targetoid, erythema, edema, and illa. That's how you were supposed to figure that one out. Okay, so be it looking cute like molluscum contagiosum or sweet like impetigo honey-crusted lesion, sores in the mouth, otherwise painless all around, is erythema multiform ulcerations for a reason. Well, don't make fun of my poems. I like it. Diagnosis. No additional testing is needed. Once clinical examination is done and you have your physical findings. Okay, so no additional testing is needed. Manage it with supportive care and topical corticosteroids. Recurrent episodes, consider suppressive antiviral therapy like acyclovir. Porphyria cutanea tarda, that's the vampire one. Clinical presentation: blister, bulla, scarring, hypopigmentation, hyperpigmentation on sun-exposed skin. For example, back of the hand, forearm, face, scarring, and calcification similar to scleroderma. Associated conditions are Hep C, HIV, excessive alcohol consumption, that's the most common one, estrogen use, and smoking. Diagnostic testing is mildly elevated liver enzymes and iron overload, elevated plasma or urine porphyrin levels. This is what it looks like from Google. I put in those photos there and there. Okay. So the history was that it was a 33-year-old female blistering on back of her hands, numerous blisters after gardening, painless because she was gardening in the sun, painless but mild itching, skin was fragile, and superficial erosion that heal with scarring. She had Hep C. Physical examination was several vesicles and erosions on the dorsum of both hands. Some lesions are healing with crusts and scars. Okay. Prior lesions appear healed with scarring and hyperpigmentation. So scarring right there. Okay. This is Pseudofolliculitis Barbae. It's the one where if they shave close to the skin basically grows faster than the follicle can grow out of the skin. So since the skin grows faster, it blocks the growth of the follicle, and then you have hair growing in under the skin. And it's painful due to shaving seen in black men, due to tightly curled facial hair. Right, so that too. Multi-blade razor cut hair below the skin, so that's why they should avoid the Gillette razor with 4 blades or something like that. Single blade is better for them, and not to go over it twice. Same area. Anyways, 10. Toxic epidermal necrolysis. That's Stevens-Johnson syndrome. So the not that, sorry. So that the difference between TEN and Stevens-Johnson syndrome is what you're going to be tested on for you to figure out what that is. So here from first aid: Stevens-Johnson syndrome, characterized by fever, bulla formation, and necrosis, sludging of skin at epidermal junction, positive Nikolsky sign, high mortality rate. Typically, mucous membranes are involved. Targetoid skin lesions may appear, as seen in the erythema multiforme, usually associated with adverse drug reactions. Toxic epidermal necrolysis (TEN) is more severe form of SJS, involving more than 30%. Okay, and body area, if it's 10 to 30% involvement, denotes SJS TEN. Okay, so less than 30 SJS, if it's more than 30 it's this, and if it's 10 to 30, less than 10 it's SJS, if it's more than 30 is TEN, and if it's between 10 to 30 it's both. Oh, okay, right there. So less than 10 body surface area covered, then SJS, 10 to 30 is both, and then more than 30 is TEN. So what does that mean? That means if you're seeing 4 to 28 days after exposure to trigger, acute influenza like prodrome, rapid onset of erythematous macules and vesicles and bullous, necrosis and sludging of epidermis or mucosal involvement, that's what you're looking out for and how much coverage it has. Right, if it's only on the face, it's probably SJS, but if it's on face and trunk, then you can think of TEN. Common triggers are allopurinol antibiotics, anticonvulsants, NSAIDs, sulfasalines. Others are mycoplasma pneumoniae, vaccination, GVHD. Right. I see skin coming off with patient, and patient is given TMP SMX. I pick SJS TEN, they were in the same options. Okay. All right. Right, so they were given TMP SMX, and I saw that in the question the skin was coming off like that. So I picked this because that was the same option. Okay. Angiofibromas, tuberous sclerosis with facial angiofibromas. You know this from step 1. Ash leaf spot right there. Right. Angiofibromas are red or flesh-colored fibrous papules that are usually located in the malar region. There, ash leaf spot is seen. This is neurofibromatosis type 1. You see multiple neurofibromas, soft skin-colored papules and nodules, and cafe outlet macules right there. Okay. Cafe outlet spot. And here you have dermatofibroma. Creates central dimple when pinched. Okay, so here they'll give you in the history that when you pinch it, it has a little dent in it, right? So you pick this because of that. So if it has a central dimple, it's dermatofibroma. Okay. Pyogenic granuloma. Benign skin tumor grows rapidly over weeks or months to a pedunculated or sessile shiny mass. It occurs over lip or oral mucosa, can bleed with minor trauma. Okay, so that's how you remember this one. It's pedunculated or sessile, and it can bleed with minor trauma and occurs over lip or oral mucosa, which is neither in this picture. Pyogenic granuloma. Okay, this is cellulitis, skin infection of the deep dermis and subcutaneous fat caused by beta hemolytic streptococcus, non-purulent type, Staphylococcus aureus, the purulent type. So if it's purulent, it's Staphylococcus aureus. If it's not purulent, then it's probably beta hemolytic streptococcus. Okay, slowly spreading rash that is warm, erythematous, and painful with flat, indistinct border. Erysipelas is this. Warm, well demarcated, bright red plaque. Right. So don't confuse this with something else. Again, it's all of these starting to look the same, but Erysipelas, they have a distinct classic presentation and vignettes. So it's limited to the epidermis and superficial dermis. They are sharp, raised versus flat in cellulitis. So that's usually the confusing one. Is it this or this, right? Uh, borders and intense erythemas. Okay, so okay. SLE. So remember how they said that it spares nasolabial folds right there. So there you go. DLE or discoid lupus is characterized by erythematous scaling plaque, predominantly affecting the face, ears, and scalp. Chronic lesions may develop depigmentation, but enlarging pigmented lesions are more characteristic of melanoma. So you can see how there's darker skin pigmentation over here, right? Same thing here. So that's DLE or discoid lupus. This is Acanthosis nigricans associated with PCOS. And then you have Pemphigus vulgaris. This is oral mucosal involvement. Yeah, right there, right there, right there, right there. So here we have this little nightmare from step one. Pemphigus vulgaris versus Bullous pemphigoid. Pemphigus vulgaris and Bullous pemphigoid. So vulgaris, age of onset is 40 to 60. Clinical features are painful, flaccid bulla, which leads to erosions. Mucosal involvement is common. History is intraepidermal cleavage and immunofluorescence net like intracellular IgG act against desmosomes. They don't test you really on any of these. It's just there to, I don't know. I didn't feel like reading it at the time, so more than 60. Pruritic tense bulla mucosal involvement rare. Subepidermal cleavage. Linear IgG against hemidesmosomes along basement membrane. This is what it looks like. So vulgaris is up here, IgG against desmosomes, and then here you have it against the basement membrane, full thickness of epithelium up here. Okay, so this is vulgaris. Vulgaris. If you, yeah, nothing. And that's also vulgaris. There's no bullous, right? And this, you would have seen bullous if it was bullous. Cutaneous small vessel vasculitis, purpura and petachi. Okay, so that's a vasculitis condition. Here you have tinea pedis or chalk itch, right? So like that, red. Uh, it's marginated, and you can see it looks like kind of a fungal growth. This happens because of dermatophytes as well. Cutaneous candidiasis or intertrigo, moist erythematous plaque under breast. Like Tinea corporis, I think, TC. Candidal intertrigo affects the warm, occluded skin inside skin folds. However, the rash typically appears moist and macerated rather than dry and scaly, lacks a clear raised border, and often shows satellite lesions. Okay, so like that, these. Erythroderma is a superficial bacterial infection, Corynebacterium, whatever that is, that presents as red or brown patches in these areas. Okay, intertriginous areas. The border is typically flat, scaling if present is fine, and itching is mild. Okay, again, this was choice B, so it wasn't tested on. Neither was this, because choice A is right there, so this wasn't tested on either. It's just their FYI. Onychomycosis, just like that. Okay. The history stated that they have rheumatoid arthritis, nail snags uh, in the stockings on the nail. Okay, so nail snag on the stockings on the nails. Okay, this is Trichophyton rubrum infection. So it's called onychomycosis. Risk factor is advanced age, Tinea Pedis, diabetes mellitus, and peripheral vascular disease. Examination findings are thick, brittle, discolored nails. Uh, Diagnosis is QH microscopy of nail scrapings, periodic acid shift stain, or culture of clippings. Treatment is mild to moderate, oral terbinafine, topical antifungals, for example, cyclopyrox and whatever that is. Moderate to severe is oral terbinafine or itraconazole. Okay, basically antifungals. Okay, psoriatic nail disease. So these are onycholysis, separation of nails from the nail bed. You'll see pitting, oil spots. Psoriasis of the nails presents with nail pitting, oil spots, and separation of the nail plate from the nail bed. Onycholysis, sorry. Tinea Pedis. This is in the foot. Okay, so Tinea Pedis dermatophyte fungi, Trichophyton species, most common. Risk factor is barefoot walking in public areas, for example, swimming pool or athletic facilities. Okay. Clinical features are interdigital type, pruritus, erythema, erosion between toes, moccasin type, so like the shoes, or sandals or whatever, those were idea of shoes. Scales fissures, extension onto the sole, side, or dorsum of the foot. Vesiculobullous type, painful bulla erythema lateral midfoot. Complications are secondary infection and recurrence. Diagnoses are clinical presentation or POK, QH microscopy of skin scraping. Treatment is first line topical antifungals, for example, miconazole, tolnafate. Second line, oral antifungals, for example, fluconazole, keep feet dry and dispose of old footwear. Significant keratosis and flaking, Trichophyton rubrum is what you will be tested on. Okay, so know the name of this dermatophyte fungi. Wood lamp examination can help visualize infection with microsporum species in patients with Tinea Pedis. Recurrent Tinea Pedis infection should examine interdigital skin of toes and have a thorough skin inspection and have any other sites of infection treated. Okay, so that's important. So if they're like scratching and stuff, treat other other sites of infection as well. That's important. Otherwise, it will reoccur. If left untreated, can lead to secondary bacterial infection like gram-positive cellulitis. Okay, so that's why. So that's why it's important to treat other areas as well. Okay, skin condition and associated disease. Know these. So skin condition and associated conditions to those. So if you have Keratosis nigricans, then Insulin resistance, it's associated with insulin resistance and gastrointestinal malignancy. If you have multiple skin tags, again, insulin resistance, or pregnancy or Crohn's disease. Perianal is usually where they're found. If you have porphyria cutanea tarda or cutaneous leucoclastic vasculitis, which is palpable purpura secondary to cryoglobulinemia, Lichen planus, they're associated with hep C. Dermatitis herpetiformis celiac disease. You know that one. Sudden onset severe psoriasis, recurrent herpes zoster, disseminated molluscum contagiosum are associated with HIV. Remember that. Disseminated molluscum contagiosum, the cute one, is associated with HIV infection. Severe seborrheic dermatitis, again, when you have, normally you have dandruff, right? But it's not bad because your immune system is good enough to fight it off. But if it's not, then it becomes a severe problem. So HIV infection or Parkinson disease. Explosive onset multiple itchy seborrheic keratosis. Gastrointestinal malignancy is what it's associated with. So seborrheic keratosis, GI malignancy. Pyoderma gangrenosum, inflammatory bowel disease. Okay, and that's it.